From Indian Journal of Anaesthesia, I, Dr. Riniki Sharma, will be presenting an article published in the April 2025 issue of the Indian Journal of Anaesthesia. It is titled Comparison of Intravenous Lignocaine-dexmedetomidine and Lignocaine-dexmedetomidine Infusion for Attenuation of Pain Response to Skull Pin Application in Patients of Intracranial Tumours, a placebo-controlled, double-blinded, randomized comparative study. Skull pin application during craniotomies triggers hemodynamic changes due to C fiber activation and sympathoadrenal reflex. Dexmedetomidine reduces the sympathetic outflow, leading to decreased norepinephrine release and attenuation of the hemodynamic response. It also enhances the analgesic effects via alpha-2 adrenoreceptors and inhibits the pain pathways. Lignocaine acts through the NMDA antagonism and sodium channel blockade, reducing the hemodynamic response and exerting analgesic effect. This study evaluates the hemodynamic stress response attenuation using IV lignocaine-dexmedetomidine and their combination in craniotomy patients. So the primary objective was to compare the hemodynamic changes after skull pin application with IV lignocaine, dexmedetomidine, and their combination. The secondary objective was find out dose of propofol needed to achieve the induction endpoint, assessment of the stress response to skull pin insertion, intrafentanyl requirement, and changes in BIS during pin insertion. Institutional Ethical Committee approval was taken and trial was registered in CTRI. It was a randomized controlled trial with ASA 1 to 2, 18 to 60 years of age and GCS more than 13, undergoing elective craniotomy for intracranial tumors. Patients with GCS less than 13, second and third degree heart block, uncontrolled hypertension, beta blocker intake, substance abuse, and known allergy to drugs were excluded from the study. Written informed consent was taken from all participants. The randomization was done using a computer-generated random number table and allocation concealment was done by SNOWS. And those who prepared the drug, administered the medications and data recorder and statistician were blinded to the group allocation. In the OT, standard ASA monitors were attached and the BIS was attached to the patient's forehead. After the IV cannula was secured, the samples were taken for serum cortisol, prolactin, blood sugar, and neutrophil lymphocyte ratio. The patients were randomized into 4 groups. In group L, IV lignocaine 2 mg per kg bolus for 15 minutes, followed by 1.5 mg per kg per hour. In group D, dexmedetomidine IV was given with 1 mg per kg bolus for 15 minutes, followed by 0.5 mg per kg per hour. In group LD, a combination of the lignocaine and dexmedetomidine in the above doses were given. And in group N, NS bolus for 15 minutes followed by 5 ml per hour was given. And for blinding, the drugs were prepared in 2 syringes and the drugs were infused over 15 minutes followed by continuous infusion up to 30 minutes after the skull pin application. So anesthesia was induced with the bolus of the studied drug and fentanyl propofol titrated to loss of verbal response and IV Vicuronium, followed by endotracheal intubation. Maintenance of anesthesia was done by oxygen, air, and sevoflurane. BIS was maintained at 40 to 60. Arterial BP cannulation was done, and CVP cannulation was done in subclavian or the IJV. The skull stabilization was done using the Mayfilm clamp or the Sugita frame. If in case of tachycardia or hypertension, all patients received fentanyl boluses of 2 mg per kg followed by propofol 20 mg boluses. For hypotension, fluid boluses were given followed by IV mefenterine 6 mg boluses. In case of bradycardia, IV atropine was used. So the primary outcome was the heart rate, a preoperative before and after indication, before skull pin application, every minute till 10 minutes and then every 5 minutes till 30 minutes. Secondary outcomes were systolic blood BP, diastolic BP, mean arterial pressure, and BIS at the above time points. Sample size was based on a previous study and a 80% power and 95% confidence interval. The study sample size was 40 patients per group and a p-value of less than 0.05 was considered significant. So after assessment for eligibility, a total of 40 patients were allocated to group L and 38 patients were analyzed in group D, 39 in the combined group LD, and 40 in the group N. So this is the baseline parameters of the all the 4 groups. So the primary outcome, which is at 0 minute and 30 minute, we can see that the combined, there is an increase in heart rate in all the 4 groups, but at 0 and 30 minutes, the least increase is in the combined group lignocaine plus dexmedetomidine group, which is significant. Similarly, for the systolic blood pressure, there is a increase in all the 3 groups from baseline, but the lowest increase is in the combined group LD. Similarly, this can be seen in the mean arterial pressure and the BIS values. So, and these values are statistically significant. Coming to the blood parameters, serum cortisol, serum prolactin, these two increased in all the 4 groups, but lowest was found in the group LD. Doses of propofol used and fentanyl consumption among the groups, we can see that the lowest amount of propofol used was in the combined group. Similarly, for the total opioid consumption was lowest in the combined group, which is statistically significant. So the combination of lignocaine and dexmedetomidine IV infusion was more effective than either drug alone in attenuating the hemodynamic and stress response during skull application in craniotomies. Significant suppression of heart rate and blood pressure fluctuations are observed with the combination. Stress hormones like cortisol and prolactin were better controlled, along with modulation of blood glucose, neuroinflammatory markers, and NLR. The results align with previous studies who found reduced opioid requirements with lignocaine, dexmedetomidine, and propofol in thyroid surgeries. The BIS changes observed in the study were also similar to findings by previous study on lignocaine infusions during abdominal surgeries. Dexmedetomidine administration demonstrated anti-inflammatory properties by reducing the interleukin-1, 6, TNF, and oxidative stress, leading to a decrease in NLR, which is a novel stress marker. The study limitations include being a single-center study limiting generalizability. Catecholamines and ACTL stage levels were not assessed. ASA 3 and 4 patients were excluded. No regional techniques were used in the control group, leading to higher opiate consumption, potentially affecting the stress response comparison. So further studies should involve multi-center studies and expanding the patient population to include high-risk cases, and comparison with regional techniques would provide additional insights into the stress response attenuation. So from this study, dexmedetomidine lignocaine IV administration is associated with few fluctuations in hemodynamic variables, decreases the neuroendocrine and neuroinflammatory stress response, and preoperative propofol and fentanyl consumption. Hence, dexmedetomidine lignocaine infusion is better for attenuating the painful response of skull fin insertion and a better alternative for opioid-free anesthesia for neurosurgical patients undergoing craniotomy for intracranial tumors. Thank you.